Okay, well, thank you and welcome to this evening's Optimizing Primary Care webinar. I'm Troy Grogan, the CEO at QHSLab, and the topic tonight is Beyond Weight Loss, the full potential of GLP-1 and GIP medications in primary care. As always, we have Dr. Marcos Sanchez-Gonzalez, our VP of Scientific and Medical Affairs, who will be moderating the seminar this evening. And we're very fortunate to have Dr. Reza Yavari. And Reza is a Yale-trained, board-certified endocrinologist with over 25 years of clinical experience, specializing in diabetes, obesity, and therapeutic lifestyle change. He's also a recognized expert in obesity management and medical weight loss, with more than a decade of experience in successfully prescribing GLP-1 receptor agonists, often at high volumes, given his background of working with type 2 diabetics. In addition to Dr. Yavari's clinical work, he is also an advisor on the medical advisory board here at QHSLab. We're also joined by Cheryl Morrison-Deutsch. She's the founder and CEO at Healthy Her, a health coaching program designed for women, by women, for women, using GLP-1 medications for weight management. With all that said, I want to turn it over to you, Dr. Sanchez-Gonzalez, to set the scene for this evening's webinar.
Thank you, Mr. Grogan. I'm so thrilled to be here. So last month, we went into the mental health world. Today, we're going to go into another world. That's why we brought the experts. But let me get you a stat. You know, I like to start with the quote of the day, but today I'm going to start with a stat. Let's start with a stat. Do you know that almost 45% of people in America is considered to be obese? And if you take that and add a little bit more to that, staggering stat, 75% of the population is overweight or obese. So this is not just about numbers and weight. This is even worse because, as we know, obesity, overweight, predisposes you to high risk of cardiometabolic diseases, type diabetes, and some cancers, yes, and cardiovascular disease, and yes, also mental health issues. Now, this metabolic crisis has been with us for the last 10 years or more. And in the last 2 or 3 years, there has been let's say, a revamp and other alternatives that we can use in the practice to help patients meet their goals, weight or health goals. Even though these drugs are not new, okay, modes of application and indications have changed, making them new drugs. But again, I'm not going to talk more about this. That's why I brought the expert to talk about GLP-1s and GIPs. And Dr. Reza, please, I know what this GLP, GIPs, I need the first name and last name. Can you illustrate, can you take us into a quick historical kind of approach to see where they come from, okay? And why we are here with these drugs today.
Well, thank you. First of all, I want to thank Troy and Marcus for the opportunity to present my experience with these drugs and hopefully to be able to answer some of your questions. As you know, I am a board-certified endocrinologist. I should, however, say that I'm not sponsored by any pharmaceutical company, and I do not represent any of the drugs in any which way that we are going to discuss tonight. I do have a lot of experience with them, so feel free to ask questions. What we're going to talk about tonight is a little bit of history, but mostly what I thought primary care physicians would want to know in terms of what medications to choose, what are the side effects, how can you mitigate them, how can you coach people who are taking these, or if you don't have time to coach them, at least identify what are the key concepts, key learning points to be able to coach them or teach your staff to coach people when they call. And then finally, how do you adjust the dose, both going up or ramping off? And some of the general dietary guidelines that are of interest for all of this. Now, before we go any further, I'm not going to go into details of this slide, but I just want to point out to you that these drugs have been around for a long time. In fact, GIP as a hormone, as a natural occurring hormone, has been known for almost 100 years. As a medication, the research was ongoing since the 1970s. In fact, when I was in training at Yale in the 1990s, we already knew these drugs existed, and there were experiments being done in labs with both GLP-1s, the GIP, the amylin type drugs, and a whole bunch of other ones. But it was only really since about 2005 that the drugs became available for diabetes management. And now Marcus showed a slide about the progression of obesity since 2014 to 2022, the previous slide. Well, 2014 was the first time I prescribed these drugs. And now 2022, the slide to the right shows you when these once-a-week drugs became available, the ones that we call Ozempic or Mounjaro. And it just shows you that the country, in the meanwhile, in the decade leading up to them, got obese. So one of the reasons that these drugs that have been available for almost 10 years got so much publicity in the media is not because of the drugs themselves, but it's also because the country has become obese. Now, the next slide shows you the difference between the mechanism of action of these drugs, the GLP-1s and the GIP. So the red panel on the left is the glucagon-like peptide 1, GLP-1 receptor agonist. And the one on the right, which has a mouthful of names, is glucose-dependent insulinotropic polypeptide, GIP receptor agonist. So they both cause, obviously, weight loss. We know that. The one on the left, GLPs, really work, GLPs work with increasing satiety, sensation of fullness, and also increasing nausea. If you eat too much, you get nauseous. On the right, on the other hand, the GIPs really decrease food intake. They take away food cravings or the food noise. And then the other effects are obviously both of them lower the blood sugar directly by impacting insulin release and glucagon. And then the GLPs have an additional benefit of cardiovascular changes that are positive, and that's, I believe, in the next slide you will see. And so the cardioprotection, cardiac output effects are predominantly GLP-1s, but the recent studies also show that GIP also has some benefit. But I just want to make a comment here real quick that Ozempic and Mounjaro, the new drugs, all are really two drugs in one. They have GLP-1 and GIP in them. So when we say Mounjaro or Zepbound also has cardiovascular benefits, it's probably because of its GLP drug that is combined with the GIP. So in any case, the GLP-1s are known to have cardioprotective effect beyond weight loss. In other words, the benefits happen at the molecular level in the arterial bed and in the heart, which don't have to do necessarily with weight loss because other weight loss drugs don't trigger the same kind of changes. And then what's interesting is on the left, GIP drugs have a direct impact. Ozempic, Mounjaro and Zepbound have a direct impact on fat metabolism, which is independent of the GLP-1. So there's a slight subtle difference between these drugs, and that has an impact on how you get a chance to choose which drug is for who. The next slide probably shows exactly the same thing, but in a different way. So the GIP and GLP-1 receptor agonist, this is now related to Mounjaro and Zepbound, remember, because it's a dual G drug, and it has positive impacts both in terms of increasing beta cell proliferation, insulin sensitivity, insulin secretion, lipolysis, and also decreases glucagon secretion, gastric emptying, appetite, and interestingly enough, we'll talk about it in a second, but it also reduces fatty deposits in the liver and elsewhere, and so on. So this is what is called a dual GIP GLP-1, or we call it dual G drug. And I think the next slide again shows that there are a lot of these drugs in the pipeline. In particular, the third one on top, retatrutide, is a triple G drug. Now, the first G is GLP-1, the second G is GIP, the third G is glucagon. And Novo Nordisk just bought the rights to a drug from China, which is also a triple G. This was just last week. And Amgen has a drug that is also a triple G. So we have to wait to see what the weight loss and the reduction in A1C is for each one of these drugs. But clearly, there's an interest in combining these drugs with glucagon. Otherwise, they wouldn't be rushing towards a triple G version of these drugs.
I like to stop here just for a second, because now we have all these options in this menu of drugs within the same family. Of course, so we know there's going to be different side effects and benefits. Uh, can you expand a little bit about differential benefits or effects of these different drugs?
Yeah, so that, Marcus, that's coming up in a few minutes about when we choose the drugs for the patients. But basically, the GLP-1 drugs work primarily on food intake. GIP drugs work primarily on food desire or food cravings. And then glucagon, I don't really know exactly how it's going to work with these two drugs, but it has a reputation of increasing burn rate, metabolic rate. So the combination of not wanting food, not being able to eat much, and also burning more calories is an ideal combination for weight loss drugs. So that's where they're going. So this is a study that compared tirzepatide, which is, again, Mounjaro or Zepbound versus semaglutide. This was a study of over 40,000 patients. And as you can see, the panel to the far left is 3 months, the middle one is 6 months, and the following one is 12 months. And it shows both for diabetics and non-diabetics, both were successful in lowering body weight by at least 5%, and then eventually at 12 months by 10 to 15%, and ultimately 20% for non-diabetics in the group that was given tirzepatide. And the next slide also further shows that the combination of the two drugs is much more effective than counseling alone. So the first two set of histograms on the left are the good old diabetes prevention program and the Look Ahead trial. The diabetes prevention program goes back to 2002, and it was followed by Look Ahead, which was to see if weight loss with counseling alone would lower the cardiovascular disease risk. And then followed by these 3 studies that are shown here. The first 2 are semaglutide, the last one is tirzepatide. Again, shows basically that even though lifestyle change and counseling is good, it's effective for preventing diabetes, but when it comes to these drugs are twice as much more effective in weight loss. And again, here, the tirzepatide group seems to be more effective. So somebody once said, well, it's all about weight loss. Well, weight loss really does matter a lot. 10% body weight loss changes not only metabolism, but changes cardiovascular risk and a lot of other benefits. But how to get there matters. And these drugs just accelerate and make that possible within a year or two to reach about 15 to 20% weight loss, which is unbelievable for a lot of people who are battling obesity. So people always ask the question, what happens when you go off these medications? Well, this is a relatively large study of over about 17,000 people, looking at people using electronic medical records, looking at people who went off the medication, and the top yellow, orange group are the people who gained some weight, if not gained all of the weight back after a year. The bottom purple, blue group are the people who either continue to lose weight or at least maintain. Now, when you look at this, you added up about 56% of the people a year out were able to either lose more weight or maintain their weight loss, which is amazing. Because as you know, with regular lifestyle change or even bariatric surgery, a large number of people, up to 90% of people gain all the way back in 5 years, if not in 2 years. So the fact that at 1 year out, people were able to continue to lose weight or at least maintain is pretty good. But it also shows, it also points to the fact that 44%, almost half of the people, regained the weight back. And my suspicion is that those are the people who were not coached, who were not educated, and who went on medications because they were desperate or they needed to go, but they didn't really seek counseling and they didn't really pursue lifestyle change. I think one of the key take-home messages today is that lifestyle change is a critical part of weight loss efforts for your patients. And not only lifestyle change matters for weight loss and weight maintenance, but also to mitigate side effects of these drugs, which is what we're going to talk about shortly. So what are some of the other benefits of these drugs before we go deeper into mechanics of using these drugs? Well, I can tell you that I'm very excited about sleep apnea because, as you know, sleep apnea is a major contributor to weight gain, to heart disease, and it's very common. And it turns out these medications, at least I should say GIP receptor agonist, Zepbound, reduces the number of apnea events even before weight loss. And my personal experience is that a lot of my patients who go on these medications, in particular Zepbound or Mounjaro, they, I should just call it tirzepatide for ease of use, they come and tell me that they sleep really well. And I never thought that these medications would have any impact on sleep before even weight loss, but they do have some direct effect on sleep quality and sleep apnea, and we yet have to study that. Both these drugs, semaglutide and tirzepatide, improve liver function tests and reverse fatty liver. And that's a big area of research for fatty liver disease and NASH. And I think that considering how many Americans, I mean, as you know, the #1 cause of cirrhosis in the US is now fatty liver. So how many US adults need this medication just for that purpose? It's amazing. So there are benefits to these drugs: cardiovascular, fatty liver, sleep disorders, and an interesting condition called lipidemia. I don't know if you know what that is, but that is the kind of subcutaneous fat that a lot of, unfortunately, women get in their legs, and it turns out to be more like, we call it cellulite or cellulite. It's more like fatty pockets that are very resistant to weight loss, and they actually retain water and hurt at the end of the day. That condition called lipidemia or lipedema, both are used, is also improved with Zepbound. And it turns out GIP drug receptor agonist, as opposed to GLP-1s, in other words, again, tirzepatide versus semaglutide, has a different beneficial effect here where it increases blood flow to subcutaneous fat, and it increases the metabolism of fat cells in the subcutaneous tissue, which are notoriously slow and sluggish in terms of metabolism. They just sit there and do nothing. So by increasing the blood flow, by increasing lipolysis in these cells, they actually make them go away. And when people go on these on tirzepatide, a lot of times I hear, "Oh my God, I can see my abs that I haven't been able to see in 20 years," or my skin fat is getting thinner,
Mhm.
or my lipedema is improving. My legs don't hurt at the end of the evening. So there's a lot we haven't studied, and there's a lot
Yeah.
more to be understood about these drugs.
It's
Dr.
amazing
Yavar,
because it's a domino effect. It's a domino-like effect of benefits and good effects. I think goes from the you were talking physical, but I can imagine you start sleeping better, your mental outlook, your mental health start to get also better. Cheryl, you were going to add something into the conversation, isn't it?
yeah. Yeah, I was going to ask Dr. Yavari, because the other thing that we're finding a lot of is helping women with gynecological issues, whether it's PCOS or perimenopause or menopause. And I don't know if you had any comments on that, because I know that's another area that they're really looking at for these benefits for these medications.
Yeah, those benefits are probably most likely related to insulin resistance. They lower insulin resistance. So I've had patients who responded to these medications, lowering their insulin resistance before they even lost weight. So once again, these medications are beneficial in ways that don't necessarily require a significant weight loss of 5 to 10% or even higher. And I have a suspicion they're going to be used in these other so-called off-label conditions, or I should say indications, for many different reasons that we can't really think about. Alzheimer is another one. I should say that these drugs are being studied for senility, in particular Alzheimer. We don't know. I don't know any details about that, but there's clearly some benefit because more and more drug companies are doing research there. So with all these drugs coming in the pipeline, similar drugs, or the G's, the double G's, the triple G's, how is one to choose what drug is best for any given patient? And I wanted to just describe my personal experience and something that is noteworthy because you don't find it in clinical studies. So a lot of my patients who come and see me go through a very thorough eating pattern screening that I do, that I've developed over the years. And it identifies people as either the kind of people that like to snack throughout the day. Those are people who are either stress eaters, or they have bad habits, or they just like to snack on sweets or salty, savory stuff, versus the people who are big eaters. They're the ones that can eat a cheeseburger and French fries and still be hungry for another second serving. People whose portions are big, whose food choices are often very fatty and high calorie. So for the former group, the group of, let's call them snackers for now. I often call them stress eaters, but let's call them snackers or grazers. Those people can eat through GLP-1s, Ozempic or Wegovy, because they can eat little by little and they can eat all day. And the mechanism of the drug, which primarily relies on gastric emptying and satiety, doesn't kick in. These people are not eating because they're hungry. They're not eating because they necessarily need to eat food of any kind. They're eating because of bad habits, or they're snackers, or they're have sometimes food addictions. So people who are snackers benefit much more from GIP receptor agonists. Those are people who I mean, that when they take these medications, they forget about food. They call it the food noise is gone. That's what they say. The cravings are gone. And then finally, when they find their snacks, whether it's salty, savory like chips, or whether it is ice cream, or whether it is any other kind of food cravings that they may have for any particular foods, when they look at it, they don't want to eat it. So the tirzepatide family of drugs, the GIP receptor agonists, work better for people who don't eat big portions, but who are snackers and have cravings. On the other hand, people who eat big portions, like typically those are big guys who can eat like a 10-ounce steak, or they can eat a cheeseburger with French fries and they want seconds, or they have pizza and they can eat a whole pizza by themselves. Those people respond much better to semaglutide in two ways. One is they get full and they just can't eat. They just don't want it. They get disgusted. And if they push it, they vomit. So they learn quickly that they cannot eat too much. I always say to them, if you could eat 4 meatballs before, now you're only going to be able to eat 2 meatballs. So this is like basically a quick way of choosing what medication works for who. The other way to choose medications is based on people's side effects, which we're going to talk about very shortly. But sometimes people respond better to certain medications. Sometimes people get used to these medications at lower doses and you have to switch them over. Those are different topics. But generally speaking, when you have snackers, pickers, grazers, think about tirzepatide. When you have big eaters, think about semaglutide, and that's a way to start. Now, as far as side effects go, you have all heard about the GI side effects. Everybody knows these medications can cause nausea, vomiting, diarrhea, constipation. And I can tell you, most of these side effects, if the dose is titrated up gradually, are manageable. People often get nauseous on these drugs. People often get heartburn. They often get sometimes gas, sometimes bloating, sometimes diarrhea on these drugs. You can titer it slowly and they will get used to it. However, there's one side effect that's common to both a family of drugs, and it's, to me, the most serious, is constipation. These drugs, both families, lower GI motility. They tend to dehydrate the GI tract, and basically people end up getting severe constipation, and it can be pretty serious. It can lead up to gut obstruction, and it can cause a lot of discomfort, sometimes panic attacks, anxiety, things like that. So what I do is I prepare people for that. Even if someone says, oh, I don't have any problem with constipation, I still prepare them for it. How do you prepare them for it? I tell them to make sure they drink a lot, make sure that they have water-soluble vegetables in their diet. We can talk in more details about that, but it's different than fiber. It's more gentle on the GI tract. It's break down easier, and it kind of helps with the bowel movements. And also the third aspect is to increase oil intake. I tell them to increase their oil intake by adding olive oil to their diet. If they don't, by even taking a tablespoon of olive oil once or twice a day, or by making their salad dressings a little bit more oily. But generally speaking, people do worse when they eat solid foods that are dry, like steak or even roasted chicken with no other additional side dish, like a legume or even oily salads. But people can mitigate the side effect of constipation by preparing in advance for it. So increase your water intake, increase oil intake, increase legumes, and generally speaking, water-soluble vegetables. And then if, again, necessary, add a stool softener. I don't usually recommend laxatives because they tend to cause a lot of discomfort if the other measures aren't first taken. So once the other measures are taken, laxatives.
What's your take on electrolytes?
So electrolytes are not directly affected by these drugs unless the person is having diarrhea, or if they're, let's say, dehydrated and they're trying to catch up with water and they only drink pure water. So I tell them, add some electrolytes to your water so that it becomes a little bit different. Sometimes electrolytes taste good and adds a little variety, but also it's good for muscle cramps and so on. and don't just drink pure water. So I tell people any kind of fluid intake is good as long as it doesn't have sugar in it, alcohol, or coffee. In other words, people can have coffee, but it doesn't count towards replenishing their hydration level. So basically, get people prepared ahead of going on these medications, because otherwise they will play catch up. The next topic is dose adjustment. Now, this is kind of interesting because we as doctors know to adjust dose gradually and go up to a certain dose, but I just want to give you a few tips. So the lowest dose of tirzepatide that's available is 2.5 milligrams weekly. That dose works. It is a starting dose, but it actually does work. It is considered a start dose. It's not considered to be therapeutic, but for a lot of people, it works enough so that they eat less. The lowest dose of semaglutide, again, Ozempic or Wegovy, that's available is 0.25. That dose is not effective in any way. So you can start someone at 0.25 and go up to 0.5 very quickly. So the test dose in the office, if you teach people how to give themselves that dose, would be 0.25. And then you go up to 0.5. And hopefully after a few weeks, if they tolerate it, they can go up to 1 milligram. I suggest that people call the office and leave a message to increase their dose when they feel like they've got used to these drugs, meaning they're eating a little bit more, they don't necessarily have side effects, they're not necessarily losing weight. And I tell them, okay, leave a message and I'll up your dose. Or sometimes in someone who's in a coaching program that is delivered through my office, I increase the dose once a month till you get to the dose where they're losing weight or they're starting to have side effects and I need to slow down the ramp up. So basically you increase the dose, use your judgment as a doctor, you increase the dose the way you can, but insurance companies have some very unusual guidelines about how to increase the dose. Pharmacy benefit plans don't tell doctors that you can't increase the dose too slow because that means the patient is not losing weight, or you can't increase the dose too fast because if they're losing weight, they don't need to go on these medications or go on a higher dose. All of that is nonsense. All of that is made up by somebody in an office. Basically, people need to increase their dose because they're getting used to it, or people need to decrease their dose because they're traveling or they have side effects or they caught a cold or something, they want to lower their dose. So those are decisions that need to be made by the patient and by the doctor and not necessarily by a PBM. But anyway, that's where we are. So since we're talking about dose increases, I might as well talk about ramp off. Again, ramp off is something that PBMs have been putting in their guidelines, but just to make it clear, again, it's a decision that you need to make with your patient. But I usually tell people if they are on a dose that they're comfortable with, let's say 5 milligrams of tirzepatide, or let's say 1 milligram of semaglutide, Ozempic, stay on that dose, but space it out. Space it out to every 10 days. So just FYI, tirzepatide is really a 5-day drug. It's not totally 7 days. And Ozempic or semaglutide is truly a 7-day drug. But even at 10 days, they're beneficial. So people choose to go every 10 days. That way, they can decide if they're comfortable with the ramp off or they start gaining the weight back. And then in which case, they already have a prescription, they can go back up to once a week. So that's one way to do it. The other way to do it is not to cancel the prescription, have them go off it, like go off to 10 days, then 2 weeks, then 1 month, and save the prescription to see if they're starting to gain the weight back, and then they can go back on it. Sometimes people take a break, they're traveling, they're going to a wedding, or other reasons they want to go off it. Now with the pen, with the Ozempic pen, you can dial it up and down and you can adjust the dose. But the other drug, tirzepatide, is a single-use pre-filled pen, you can't adjust the dose. So that's why you kind of change the timing of it. So that's kind of like the way you do the ramp up the best you can. But there are no consensus on the guidelines how to do it. There's no society guidelines how to taper people off. Now we're getting to basically the two topics that are the hardest, which is the dietary guidelines and the behavior modification. I'll try to make it as simple as possible. The dietary guideline, if you want, you can think of it in one sentence. If you want your patient to succeed, teach them how to eat wet foods. That's it, wet foods, meaning avoid dry foods that tend to plug their intestines. They tend to cause a lot of trouble. But wet foods such as stews, pot roasts, soups provide not only can provide the protein, but also they provide other nutrients and hydration. So if somebody goes on a steak and protein bar diet, I guarantee you that they will not stay on this medication long enough, because either they'll get severely constipated or have bloating and IBS-like symptoms, or they will have micronutrient deficiencies and they start losing hair, their skin changes, they start catching colds a lot, and they just don't feel good. So the best way to coach people is to have them meet their protein target, but at the same time, make sure they don't forget about vitamins, antioxidants, minerals, and other micronutrients that are rich in vegetables and in fruits. So what I tell people is I give them protein guidelines, basically somewhere between 100 and 150 grams of protein a day. And then we work out ways that they can kind of put that in their daily routine. Some people like to eat more in the morning. Some people can eat more in the afternoon. Some people have to catch up in the evening. But the important message here is don't just focus on protein because you have heard of Ozempic face or Ozempic butt, which is like the muscle loss in social media. What you want to do is you want to educate people, encourage them to take the protein, but at the same time, don't forget about micronutrients. Now,
I don't want
to. Yeah, go ahead.
I want to pause here a little bit, because I know you have been working on your books and your work. So when we go into dietary guidelines, that's one thing, okay? But at the same time, we need to consider that sometimes, ethically speaking or ethnically speaking, some cultures, they have naturally foods that are friendly for these medications, while other cultures, they have food that they're not necessarily friendly for this. So in those cases, how you basically manage and coach this kind of patient in order to bring them into the recommended foods for these kind of treatments?
So, Marcos, on these medications, nobody eats enough food. So these medications literally make starvation possible. So the point is, okay, let's say you come from Eastern Europe and you like a lot of fatty, kind of processed meats like sausage, or very heavy meats that are in pot roast, things like that, or as opposed to somebody who's more like eating beans and rice and maybe a little bit of protein in their diet. Well, in all cases, they're not going to eat much of any of that. So they have to eat. They have to start from scratch. They have to learn to eat enough protein, and you have to help them figure out where that protein comes from. Usually, some of it comes from a shake because that's the only way that they can catch up. And then they have to eat the vegetables and the fruits of their choice that they're used to, that's in their diet. So obviously, you want to eliminate all the fatty choices, such as very heavy cheesy dishes or very greasy dishes, because one, that's not good for them. Two, they throw up, and it's more likely that they'll say, well, I'm not going to take this medication because every time I eat something, I throw up. So you want it to be a very clean diet. Avoid like chicken parmesan, avoid lasagna, avoid hot dogs, avoid all kinds of very greasy foods. Lots of French pate is not good for you. And, honestly, a lot of the calories in pate come from fat anyway. So they don't come from protein. So what you want to do is you want to steer them towards a direction where they can eat the protein of their choice and then the vegetable of their choice. And they need to understand that it's not just about eating protein, that they have to come up. So I often ask people when I tell them you have to eat vegetables, I don't like vegetables. Well, what kind of vegetables would you eat if you had to? Well, I could handle zucchini, you know. I said, okay, well, that's good. You can handle
I
zucchini.
know.
That's relatively mild. But, so you kind of negotiate. But the point is, start from the understanding that this is a starvation medication. So, and then you add to it, as opposed to the old-fashioned dietary guidelines, which was all restrictive. Cut this out, cut that out, cut the carbs out, cut the starches out, cut the fat out, cut the salt out. We are past that point. We're basically dealing with a situation where we're hoping our patients get 1,000 calories a day. Most of my patients come and see me and they're eating 500 calories a day, which is not food for any human being. I mean,
And this is where some of the mental health issues come into play as well. These are people who may not have been able to follow restrictive diets in the past, and they find that they're not hungry all day. They think it's great that they don't want breakfast and lunch, and they go for way too long without eating. And I think you need to address kind of both sides of that, because now you're teaching people really to eat to live, and that eating is not restricted. And there's a heavy emotional component on that end as well. So it's really addressing both issues and making sure that people understand that they have the freedom to eat, that they really are eating to do better on these things, to stay on them for longer, to continue to get the success, because they feel the early success and they tend to restrict. So it really is turning kind of diet culture on its head and teaching people to actually eat to live better as opposed to restrict.
Yeah, great. So yes, absolutely. And the other thing is that you have to customize your coaching. You have to personalize it to every person. And that leads me to the next topic, which is behavior modification. Without behavior modification, all this effort that we've been talking about, all this work will eventually be doomed. Because if you don't change someone's behavior in terms of eating habits, lifestyle in general, stress reduction, exercise, psychological issues such as like setting boundaries, learning skills you need to continue weight loss, changing mindsets. If you don't do that, what's going to happen is basically these people are going to maybe hopefully lose weight and they feel great, but eventually they'll go back to their old habits and they'll gain all the way back. Maybe not right away, hopefully. Maybe they'll benefit from a few years of lesser weight, but eventually they'll relapse. So the behavior modification approach with these drugs is similar to other coaching mechanism in the sense that you have to teach people, you have to educate people, you have to motivate people, you have to teach people skills, the skills like time management, organizational skills, problem solving, mindfulness, setting boundaries. These are all important. And some of these will be discussed in my upcoming book. They're also the focus of my app, which, thank you, Marcos, is showing here, which is Beyond Weight. And it's also the focus of Cheryl's efforts with Healthy Hers, or in general, a women's health focus for weight loss on these drugs. But so what you would have to do is you would have to teach people how to shop, cook, and eat, which is the job of really more than just a primary care visit. So what you would have to do is for behavior modification, you would have to refer people out, I'm afraid, or you would have to give them resources such as QHSLab, my app, Cheryl's app, that are out there that help people learn different skills, different mindsets, so that they can continue their efforts with weight loss. One of the hardest things that I deal with is, what do you do for, let's say, a mother who's losing weight and now she has to worry about what to cook for her kids or her husband, because she's basically not interested in eating because she's not eating much of these drugs. And then what do you do for people who may have like business related activities where they feel obligated to go to restaurants and eat business dinners or lunches while they can't eat? What do you do for people who like have battled cravings all their lives, and sometimes they have family members who sabotage their efforts by bringing those foods they crave home just because they feel like they would be doing them some pleasure, or maybe sometimes even to tease them. So there are all these dynamics that are involved, and those are not something that a primary care physician has time to do in an office. So I think the best thing that primary care physicians can do is educate themselves and be aware of this huge component of lifestyle change and refer people to the resources that they would benefit from it. So my app, thank you, Marcos, it's called Beyond Weight. It's basically a 6-month digital coaching program that doesn't have any live coaching in it. So it's very affordable. It's basically going to be offered to you as members of QHSLab and your patients for free. And it not only works on educating people with lessons and so on, and the next slide shows you it has meal plans that are customized to people's body composition. It has a lot of motivational daily nudges and quizzes that are pushed to the user so that the user stays engaged. And on top of it, I have written a book that goes with it. It's called Beyond Weight Culinary Companion, which has a lot of very useful educational information, but also very yummy recipes that people can use. And this app is available through the link at the bottom of the screen, but it will be available through QHS resources for any of your patients who want to use it for free for 6 months, from the time they start till the time they finish. And we've got very good results with it. And I know Cheryl is waiting to put a pitch for her efforts that actually overlap with mine a little bit, except she's more focused on women.
Yeah.
So this is interesting because we go from we have in the platform a way to identify the patients that have these help-seeking behavioral. Yeah, I would like help with my weight management, and then physicians, as you mentioned, probably we don't have the training in these particular concepts, and then we have these resources through the health journeys for sleep or for weight management, sorry, and exercise and so on. And what a wonderful resource. In 6 months, many of the patients can benefit, and many of them they need 3 months, 4 months, and they will achieve their goal of a healthy weight. And then comes to Cheryl. This is no one size fits all. We need to have, there's no silver bullet in medicine. We know that. So what makes Healthy Hair different as a coaching product for weight management and the use of and integrating these drugs along that health journey for the patients?
Right. We're one of the few programs that is written specifically for women in supporting their health journeys and managing their chronic conditions, but that is specifically also written to work with GLP-1 and GIP medications. So we have an app that features physician-reviewed evidence-based resources on topics including physical, mental, and social health. We believe all of those areas are important for whole health and shouldn't be ignored. We also pair our members with a personal health coach who supports them and encourages them with weekly texting, monthly phone calls, and video calls, so that they have access to this person throughout their journey. And then we also have a private community. We're finding that a lot of women are going out into social media sites, joining these areas and getting information about things that are not from doctors, that are not well researched. And so we've created a safe private community where all of the areas are moderated and supported. And so all of those things combined together help women during their entire journey. So while they're on the medications, as Dr. Yavari talked about, eating the right things, getting feedback on that on a more daily and weekly basis from the people in their community, as well as their health coach, as well as the content. But then, so that's during their journey. It helps them achieve and recognize their goals and get there. And then it helps them learn those types of habits and changes to sustain those goals, and creating, again, that community around them so that they're always learning from each other and they feel supported. So that's a lot about why Healthy Her is different. We want to be that proactive solution to help with the challenges we've just talked about, and help people have, women especially, have lasting and better outcomes.
And something that also piqued my attention throughout all the additional benefits that come along with the drugs and the lifestyle modifications. There's a particular set of patients that are close to my heart, are those with inflammatory diseases.
Yes.
And those are the rheumatoid arthritis of the world and very severe allergies and so on. What is your experience on these patients with these comorbidities as they engage in this holistic program? What in the experience of the outcomes that these programs impact their life? How these programs impact their life overall? What is your experience on that? Just curious.
I can talk to kind of my members and what they've experienced, and I'm sure Dr. Yavari can talk about kind of the medical theory behind it. But these women have come in and they have improved their overall symptoms because their inflammation goes down and decreases dramatically, making them feel more mobile, have more energy, less brain fog, and overall feel better. We've had a number of our members who had PCOS and reduced their insulin resistance and have gone on to get pregnant actually without the help of a lot of additional infertility treatments. They were able to kind of take control of the processes in their body using these medications and making these changes. And that's made an incredible difference for people out there. And that's actually why I do what I do, is seeing the impact that it's had on these women. And it's tremendous. And Dr. Yavari, I know you have more to say on that.
Well, yeah, we do measure inflammatory markers, biometrics, and we also correlate in our regular visits how the patient is feeling when they go on these drugs. And I can tell you, there's additional benefits beyond weight loss here as well. And some of it has to do with the fact that they're eating less pro-inflammatory foods, so to speak, processed foods, foods that are rich in fat, foods that are rich in enriched starches. And some of it, of course, has to do with insulin resistance, but it's probably a multifactorial thing. But I've had patients whose psoriasis have got better. I've had patients whose joint pains get better. And it's hard for me personally to say it's because of the drug or because of this or that, but definitely the anti-inflammatory benefits are clearly there.
And I'll put it out there. I've gotten a number of patients referred from Dr. Yavari, a number of women in, and I think it's going very well because we can partner together to make sure that, we aren't a replacement for primary care or physicians. We are a support to them. We can raise concerns and have people go back to their primary care when they need to, but also when they don't, and they just need to remember to drink their water and eat enough protein and kind of keep track of their side effects and keep track of their usage of the medication. We can do that and then work together with the physician to manage and titrate and take care of all of the other pieces.
This is amazing because there's so many features that the platform is coming up. I know Troy and the developing team, they don't sleep. These guys, they don't sleep. They're just looking at improvement to the platform to make the life of the physician easier. Because now I don't have to be looking around. Where is the information of the patient? If the patient wants help or not? But I'll allow Troy to let us a little bit more into how I identify these patients and how they are directed into resources such as Beyond Weight and Healthy Hairs.
Yeah, well, all our digital medicine assessments, whether that be mental health focused or allergy focused or medical nutrition assessments or sleep apnea, they always ask these help-seeking behavior questions based on risk. Are you interested in the following? Are you interested in weight loss? Are you interested in emotional well-being? And so when patients do self-select, when they put their hand up and say, yes, I'm interested in weight loss, then we can share these health journeys. And part of the health journeys is the link, and what Dr. Yavari just mentioned is access to his app free of charge. We're doing research. We're a research-based company. We're looking to see, does these programs work in a real world concept, situation? So please get that link out of the chat. Use it with your patients. We'll be following it. All our other health journeys will align: our obesity, our Eat Well program, our Smart Move program. If you've got chronic pain patients, this is perfect for patients that have chronic pain. Cheryl's program will be available as well for women. And Cheryl, you may want to just mention this is cash pay. It's not covered by insurance, and you have lots of women that are really keen to be, out of pocket, making sure that they've got the right support. We also put a link in there for folks that just want more information. You can speak with your QHSLab account representative, of course, or you can fill out the form that we put in the chat there, and then we'll provide more access to information that way as well.
Excellent. So I was showing some of the resources, okay? But this is a some time ago in Dr. M series, I remember I make a kind of a post about what about those patients that they say, no, I don't want help now, but they're not ready for change. And it seems with the data that Dr. Reza presented today, that the key of success, the drug is doing its job, but the key of success is that combination of the drug and the behavioral modification. So can you give us some tips of that, the patient that, doctor, I'm not ready for change. I don't want to change. What are some of the strategies to make sure that the patient understand that this is in the best of their interest to start these kind of programs, because they are otherwise at increased cardiometabolic risk, mental health risk, and so on?
So one of the key features of motivational interviewing is to ask questions instead of telling patients what to do, is to lead them by asking them the right questions. And asking the right questions help you understand whether they're ready or whether they are at a different stage in their cognitive process for change. If you understand from your interviewing that the patient is, let's say, in denial, or they're such novice, they're like, let's say 22 years old, and they have no clue as to all the pieces of a weight loss effort, then what you have to do is you have to keep them linked to your office, to your program, to your efforts, and slowly educate them by providing them resources so that they can pursue it. If, on the other hand, the person has hesitations, they have reservations about medications, or they have personal issues related to body image and all that, then there are different solutions to that. But the first step is really asking the right questions and trying to come up with a personalized approach, even at those early stages.
That's a great answer, because we have, again, the patient that usually is looking for the help, it's ready for that change, and it's willing to make those sacrifices, so to speak. But with the right guidance, probably the patient that is not ready at that particular point, again, with the right questioning and education, and why this is important in the context of overall well-being, should be able to go from that area of I don't want to do this, to okay, the patient could feel empowered. Something else that we are as of lately looking into, asking these questions in the privacy of your own device, whether it's a computer or phone. Research have suggested that you're more likely to be more sincere to say yes, okay, or to take out that stigma of body weight management. They're gonna tell me that I'm obese, or what if in the office they know I'm using this medication. With mental health, the stigma, as we know, it's huge. How about the stigma of some people using this drug? It's becoming now famous because pretty much Hollywood, everyone is using it. So that stigma is there, but still we have some patients that stigma is kind of that barrier. What are some of the key conversations you may have, or key suggestions you have for the practitioners to help that kind of patients?
Yeah, so I'm going to let Cheryl answer that, but in my opinion, in spite of all the news and social media exposure, most patients do not want to tell their colleagues or their even family or friends that they're taking medications, and that's a mistake that to some degree all doctors and healthcare professionals are responsible for. And I think educating people that obesity is a condition, it's not a failure, it's not a setback, but it is a disease condition. And there are tools to get around it and deal with it. And also removing the stigma of using medications for weight loss, I think would help. But Cheryl, I'm sure you have a lot of feedback from your women patients or clients who are online that in the focus groups, I mean, the group sessions and all that, because people talk about that.
They talk about it all the time. I think that there are a lot of people that were afraid to go to their doctor and ask about these medications because they felt like they would be judged. They felt like, you know, they would be told that they were somehow looking to cheat and that they didn't need that. They should just work harder. And so getting people over that kind of hurdle has been a big piece of what we do. And talking to people about, yes, you know, but if there were other health conditions you had and there was a medication that could help you, wouldn't you want to take that medication? And so why is this different? But we also go into with folks that we're working with, these women, a lot about the holidays. And you're going to the holidays and you're eating less and you've lost a little weight and you don't want to attract the attention. And how do you manage that? How do you, who do you tell that you're on these medications? If someone says, oh, you're looking great, what have you done? Nobody wants to say they're on the medications because they're all afraid of being judged. So we spend a lot of time in the group sessions talking about comebacks, talking about ways to manage that and to deal with that. Exactly, the word stigma is exactly what I would use in how to address these issues. But it's taking that first step and realizing you're not cheating, but that you're giving yourself every opportunity to be successful.
So we have many practitioners that tells the patient, yeah, diet and exercise. Diet. What is that? What is diet? What is exercise? And we don't have the time in the time allocated in the office to cover this. But I mean, here, if you're a QHSLab user, you can redirect your patients. And yes, there's some resources there for you in the health journeys that can aid in that help. And if you want to zoom in all the way to Beyond Weight or Healthy Hairs, you will have that opportunity in those areas, particular areas that are they're so easy to say, diet and exercise, but so difficult to explain, especially when you're seeking a behavioral change that will impact the life of that person, hopefully for the rest of the life.
And you hit on a really important point. It is much easier on a device or on a, you know, whether it's an iPad or a phone or interacting with a device to say you're looking for something like that than to walk in and have to have the conversation. So if you can start it by being online, by letting someone know that you are interested, it can ease that conversation and you don't, it doesn't become a confrontation, it just becomes a conversation. I think that's really important.
There you go. There you go. So,
Yeah,
Mr. Grogan.
we do have a question here. If I just let that person actually speak, is it Guerta? I have to unmute you by the looks of it. Ask to unmute.
Well, that question was answered. Thank you so much.
Oh, great. What was the question? Just so we all know.
Oh, no, it was about, it was answered earlier regarding how the benefit for women. I'm a provider in Texas, and I see a lot of women with PCOS, inflammation, massive inflammation, and also the stigma of not wanting to take the drugs because of society. Yeah.
So
How to approach that.
Yeah,
Well,
finding a
great.
supportive community that can be online where you can be, it's not your real name and your phone, it's a username. So you have that anonymity in dealing with the community. You have your coach who has your name, and then you have the resources at your fingertips. Sometimes make all of that much easier.
Yeah, that's great. This is really great.
Great, Dr. Johnson. If you're interested in anyone else on the webinar, we did post in the chat, and of course we'll be following up this webinar with some email communication to everyone on our great list with the recording of this event and access to Dr. Yavari's program and Cheryl's program as well. So this has been another fantastic session. Thank you for everyone's participation. The Optimizing Primary Care series will continue, and by popular demand, when we hear of topics that people are interested in, we're more than willing to put experts in front of people and answer questions and align people's goals with good quality medicine, and hopefully even enhance their practice in many ways as well.
Thank you for having us.
Yes, thank you for the opportunity.
So some final words here. Remember, everyone, that if you're looking for tools basically to improve your clinical decision making, also to basically empower your patients and lead them into a better education and be your health journey's companion, and why not probably help generate more revenue in your practice, contact us at QHSLab. So we're always happy to answer any question, see how these digital medicine and digital health tools can help you in your practices. And thank you again, Dr. Yavari. Thank you, Mrs. Morrison. It's been great having you. I think we're just the tip of the iceberg. There's so much here on lifestyle medicine that I want to hear, and how we can use all these tools that we have in the disposal. Because 20 years ago, we have to do this pretty much in person or over a boring phone, and now we have all these technologies to help us deliver digital interventions, health promotions programs in a remote manner. So accessibility has improved. So there's pretty much no excuse if you have a connection to have access to these magnificent resources.
And
Thank
before we
you.
go, we do have another question here. This is live, so we can take more questions. So is it Dr. Hernandez? Are you there?
Yes, I'm here. Thank you. Thank you. Everything is good. Thank you. Practices with the patient and diabetes and weight loss program, but at this time, everything is okay.
Oh, great.
Great.
Fantastic.
Great.
All right, everyone. You have a great evening, and we'll see you in cyberspace.
All right.
you,
Thank you
everyone.
very much. Good evening.
Bye-bye.